So we talked about dermatomyositis a little bit yesterday. Uh, Tayson, what do you think of this case?
There's some low density or low signal mass there in the volar aspect of the thumb.
Okay, so there's a big soft tissue, kind of uniform lesion that's moderately low in signal intensity on the T1, uh, pretty dark on the fat suppressed sequences. A little tendinopathy here in the fourth, which we can see. All right, and then there's some other images through that lesion, which was palpable on the skin.
Yeah, I'm not exactly sure what that is.
Okay, and here we go as well. Maybe some skin thickening here as well. Okay.
Okay.
This is a patient with scleroderma. So scleroderma can look like a lot of things, and you've all probably in medical school examined patients who had scleroderma and board-like skin, very tough skin. So it's just fibrous tissue, uh, uh, typically thought to be due to chronic inflammatory changes within the subcutaneous tissues, but it can have a variable appearance on MR. But these one of the causes of having fibrous-like soft tissue signal intensity is scleroderma. Okay, Elior.
All right, so 48-year-old woman, forearm swelling and hardness, bug bite 3 months ago, developed swelling, cellulitis, impression, no response to antibiotics. On the FATSAT PD image on the left, we see circumferential soft tissue edema within the muscles, along the muscle fascia, really in all compartments.
Okay.
Yeah, I'd be worried about infection given this bug bite.
Certainly infection. It certainly looks like it's inflammatory, doesn't it? But
Yes.
we don't really see a lot of just like fluid collection.
Right.
So usual infections that we get with cellulitis from bacteria, you'll often see fluid collections and little abscesses and so forth. But we see a lot of edema, and it seems like it's primarily thickening that's going on the fascia surrounding the muscles, though there's some inside the muscles.
Mm-hmm.
Here are some coronal images, which just shows a little bit of increased signal intensity along the tendon sheaths, probably in the synovium of the tendons. And then if we, here's some more labs that are a little bit abnormal.
Mm.
And
well, could it be an atypical infection? Maybe like a fungal infection, maybe.
Okay. Yeah, good. Okay. Yeah, so the clinical diagnosis was indeed that it was cellulitis with fasciitis. So they put the patient on antibiotic therapy, and this is 20 days later after being on antibiotics.
It looks very similar.
Yeah.
Oops.
And this was eosinophilic fasciitis, which is probably more of a immunologic reaction, often to drugs or tissue, that the body kind of reacts to. It's more of an allergic type reaction rather than an actual true infection. Okay, Tayson.
All right, 18-year-old male, right arm pain for 2 months. So again, it looks like there's some edema fluid within the fascial planes of the arm there, and maybe also in the chest wall there as well.
Okay. Just ultrasound. Then here we can see other images.
Yeah, it looks,
So
yeah,
again,
there's
it
no
looks like it's,
discrete fluid collection, but yeah, there's fluid tracking along all these fascial planes.
yeah, so it really looks like edema within the fascia. So this really looks like another fasciitis, primarily involving fascial planes rather than the muscles themselves, with enhancement of the abnormal fascia of the fascial planes. And here we can see in this patient, the eosinophil count is very high. And then they did a biopsy and they came back scleroderma and kind of chronic inflammatory changes, but they had a lot of focal eosinophilic infiltration. And so this was thought to be eosinophilic fasciitis as well.
Okay.
So it's a scleroderma-like disorder with extremity induration and skin induration. As you can see here, often the diagnosis is made by biopsy, and it shows a lot of eosinophilics infiltrate where there really shouldn't be, which is an indication of a immunologic allergic type reaction. And this is just other examples of eosinophilic fasciitis, showing that thickening of the fascia between the muscles. And typically treated with corticosteroids. Though now there may be more specific drugs becoming available besides just steroids. Okay, Elior.
Okay, we have a 55-year-old female with mixed connective tissue disease. Okay, so we're pointing at a normal tuft, that fourth digit, but looks like the tufts of the second and third are eroded.
Okay.
Um,
There's some slightly different plane. And we see
Right.
decreased fat within the tuft here, and this tuft really is eroded of the second.
Right. Is this forget the name, acro-osteolysis or
Acro-osteolysis? Yeah.
acro-osteolysis? Yes.
Here we can see uh, that tufts being gone here as well. So what's the differential diagnosis of acro-osteolysis?
I think it can be seen with scleroderma.
Okay.
Some kind of, I think, endocrine disorders, maybe parathyroid.
Hyperparathyroidism.
Mm-hmm.
Yeah, and it can be done with electric shock. You can also have it with frostbite. Typically around here, we see it from chronic surfers who are in cold water a lot, and they'll get Raynaud's phenomenon and ischemic resorption of the distal tufts. Tayson, what do you think of this case?
All right, so the skin around the distal phalanx of the thumb looks a little irregular there, and then there's an erosion at the distal tuft of the middle finger.
Okay. Well, and maybe a little bit of increased density in the soft tissues there.
It's lupus.
Yeah. Okay. Well, I'm sorry about this, but I'm okay. So this is another case. Oh, here we go. This is systemic lupus erythematosus, which is another cause of acro-osteolysis, which you can see, and you can often get skin changes and lupus as well. Lupus has many different organs that it can involve. You can get myositis, tendon weakness and ruptures. It's commonly associated with osteonecrosis. That's the most common finding that we typically see, that I've typically seen over the years looking at MRs, is patient comes in with multiple bone infarcts on an EMR scan, and then you work it up, and it turns out that the SLE is the systemic lupus erythematosus is the differential in the differential cause, and it's another cause of soft tissue calcifications and tuft resorption. Commonly with lupus, you get pretty much symmetric involvement of the hands and the long bones, pleural effusions, thickening, cardiomegaly. And let's see. Okay. See, Elio, are you next?
Yes.
Okay.
So, right, we see this increased signal, the subcutaneous soft tissues, dorsal, ulnar-sided hand. It's unlike any edema that we usually see. On the T1 post-contrast, it's low signal. Not sure if there's enhancement or not.
Yeah, without a T1 fat sat pre, we can't really determine whether there's enhancement. We've talked about repeatedly.
So it's like this. It's like a soft tissue infiltration. It looks like fibrosis, or
looks kind of fibrous, doesn't it?
Yes.
And this turned out to be sarcoidosis.
Okay.
Yeah. And typically it's seen with kind of subcutaneous honeycombing and poorly enhancing lesions on the skin. Okay, Tayson?
All right, over at that marker at the medial gastrocnemius muscle, you see edema within the muscle there, maybe some central low signal there too.
Right, which is a bit odd. Ultrasound, we can see some vascularity here. And this turned out to be sarcoidosis of the muscles. So it's a bit different than the usual edema we see in the muscle, like from a contusion or a partial tear, where it's kind of diffusely increased signal intensity. It just has a kind of an odd kind of appearance that just doesn't look like an acute traumatic type problem.
Yeah.
This is sarcoid, which is more of an inflammatory lesion. And non-caseating granulomas, as you all know.
So is that low signal there what we think is a granuloma?
No, I think a granuloma would be more well-defined and nodular in appearance. I think this comes from chronic inflammation, and you probably get some fibrosis inside the area of chronic inflammation.
Okay.
And it can be kind of hard to the field touch as well. Okay, and you can get involved with the bones, the joints, and the muscles. And it gives it kind of a lace-like appearance. I think I have an example of what that looks like on plain films coming up. And with radiograph by MR, you can just see inflammatory changes within the bone. And so this is the typical appearance of the lace-like appearance on plain radiographs that you can see in sarcoidosis. We have focal areas where you have inflammatory disease within the bone that resorbs the trabecular bone, like we've been talking about, and you're left with these kind of thickened trabecula in areas of of resorbed trabecula due to the inflammatory disease of sarcoid. And that's another example, sarcoid with involvement of the soft tissues around it, a little bit of calcifications within the soft tissues. Again, here we can see bone involvement as well as soft tissue involvement. And here the appearance is not typical of the kind of usual infection that we see. It looks a little almost more like tumor-like in its characteristics. And you can also get involved with the large bones. The small bones, you typically get that lace-like appearance. And then larger bones, you can get larger, more rounded type of lesions that look a little bit more like masses. And the differential diagnosis is often osteoplastic metastases, Paget's disease, renal osteodystrophy, lymphoma, tuberous sclerosis, and sickle cell anemia. And here are the kind of findings that you can see in sarcoidosis. Other lesions of sarcoidosis. And the tendons can also be involved. And it's another disease that can produce such-like dactylitis of the fingers, which I'm not sure I've ever seen in this disease. Generally, when I've seen it, it's been in psoriatic arthritis. And here's the tenosynovitis that you can get. Looks like an inflammatory condition. And there's a variant, the Lofgren syndrome, where you get arthralgias, erythematosus, bilateral lymphadenopathy within the hilum. And this is, you can get a more systemic, acute type disease due to the circulating inflammatory cytokines. And it can also get involved with the muscles. And here's an involvement of the muscle. Okay, Elior.
We've got a 47-year-old woman, dry eye and mouth for 17 years, right wrist swelling and pain. Seems to be some sclerosis in the carpal bones, particularly at the articulations.
Okay, well, what do you think, just if we just start with the dry eye and mouth, does that ring any bells?
Sjogren's.
Okay, there we can see this is 4 months later, kind of progression of the bone disease. Seems mark activity on the bone scan. And other examples. Here we can see both osteitis within the bones of the wrist as well as tenosynovitis on the flexor tendons. And they finally, these particular patients will commonly have symptoms of rheumatoid arthritis. The biopsy shows active inflammatory disease, and this is Sjogren syndrome. Now, Sjogren syndrome usually just presents with the dry eyes and mouth, but it is an inflammatory condition, and it can involve other parts of the body, though not nearly as common as just the dry eyes and the dry mouth. But Sjogren syndrome can involve the tendons, the bones, and the joints. Okay, Tayson.
All right. 58-year-old male hand and wrist is swelling, concern for tumor. Am I just seeing a flexed finger there, or
Yeah, I don't know whether that's fixed or the joints look like they're kind of okay, but yeah, that's a possibility that they could be flexed and couldn't extend out, in which case you might have a flexor tendon problem.
yeah.
They're concerned about carpal tunnel syndrome, which certainly would have to do with the flexor tendons. And I don't see it. You can see that there is maybe a little bit of calcification here in the region of the flexor tendons. Here's the MR examination. So presumably now those fingers are flexed and can't be extended. What do you see here?
Yeah, and the lateral aspect of the carpal bones, a lot of soft tissue thickening there.
Yeah. And here are the axial images.
Yeah, it's like encasing all the flexor tendons with some fluid.
Yeah, I don't know. This literally looks like soft tissue to me. I think this is some sort of either infiltrative process or synovial hypertrophy involving the flexor tendons here. And with separation, it really looks like this may be a lot of synovial thickening coming down here among the flexor tendons. Any idea what this could be?
Not sure.
Yeah. And I guess it could be an atypical infection where you get a lot of this. Rheumatoid arthritis is certainly a little different than I typically seen in the past rheumatoid arthritis involving tenosynovitis, but this could be tenosynovitis. Um, but weird things that don't look like they have a lot of necessarily edema, though they can. Uh, but you get soft tissue thickening both within tendons and within the tendon sheaths. Always think about gout. And
Okay.
in this particular case, this is all gout involving the synovium of the flexor tendons, which is leading to carpal tunnel syndrome in this patient with gout. Okay, Elior.
54-year-old, fifth finger pain and swelling. Yeah, regularity of that fifth flexor tendon. Uh, yeah, those fibers just look frayed.
And then it looks like there's this kind of intermediate signal intensity stuff here within inside both the tendon
Mm-hmm.
and within the synovium.
Mm-hmm.
When you see that one, it looks just very kind of bizarre. And I think we saw some where it kind of looked a little bit like this on the Achilles tendon when we did the ankles also with gout. Uh, this is this was gout, also primarily involving the soft tissues and the tendon sheaths and the tendons. Okay, Tayson.
Or 75-year-old male with chronic wrist pain. Uh, some irregularity of the cortex there on the radial side of the radius, maybe?
Okay, a little bit in here. Probably some soft tissue thickening also around the carpal bones.
Yeah.
Kind of, kind of irregular density within the bones themselves. Here's a CT scan.
All right, so it looks like there's some mineral densities there next to this erosion in the triquetrum.
So we have soft tissue and increased density, and then these erosive changes within the bones. I don't really see any spiculated margins.
Yeah.
We can see a lot of increased density within the tendon sheaths. And then again, around the tendons with erosions. And whenever you see this, you really have to think about gout.
Okay.
And this was gout. And again, if you have CT, if you have a dual energy, you could confirm it by just doing a dual energy scan. And remember, uh, gouty crystals and the bone really have absorbed the radiation at different frequencies, so you can differentiate the two and actually come up with a scan just of the urate crystals separate from the from calcium. Okay, Tayson?
Yeah, so I think this one has a little bit more of a classic appearance of what you expect with gout, with these overhanging edges from
Right.
these erosions.
Good. Yeah. And then here we can see a lot of shadowing here among the tendons. And this was gout. Elior?
Sure. Yeah, we've got erosions again. The metacarpal head there, I think at the third. Yeah, we could think of gout again. I mean, those margins look
Yeah, a
pretty sharp.
lot of soft tissue thickening here as well.
Mm-hmm.
The increased signal intensity is relatively sharply defined. So this doesn't really look like the typical osteitis we would see in early active rheumatoid arthritis, but it could be in later, more mature erosive changes. This looks a little bit more like degenerative disease with some joint space narrowing there. And again, we see similar things on the axial images. And this was also gout. And if you remember, I think we went through this in the inflammatory lecture. What causes gout is you get the uric acid crystallizing into these crystals. These crystals are long and they're needle-like, as we see here. The macrophages come and try to engulf them and dissolve them to get rid of them. But what happens is when they do that, the crystals actually will penetrate the cell walls of the macrophages, causing the internal biochemicals of the macrophage to spill out into the surrounding soft tissues. Those are highly inflammatory, produce a very strong inflammatory reaction. So what the body is really reacting to is not the uric acid crystal per se. They're reacting to the spilling of the biochemistry from within the macrophage into the soft tissues due to the mechanical disruption of the macrophage's cell wall. So it's a very interesting type of pathophysiology in gout. Okay, I don't know. Who's next?
Yeah, I can go. It's fine.
Okay, good.
Right, just erosion of the that first proximal phalanx. Yeah, the distal phalanges.
Yeah.
With the soft tissue thickening adjacent to these erosions, I would think of gout again.
Yeah, speculated margins, very classic.
Mm-hmm.
Speculated sharp margins, speculated margin, speculated margins. Not something you would see in rheumatoid arthritis. Speculated margins.
Mm-hmm.
Look at those sharp little points there. And this is severe gout. Okay, Tayson.
All right, proximal phalanx of the second digit there. A lot of soft tissue thickening and erosion with spiculated margin there.
That's what the MR looked like, the sagittal plane.
Yeah, so that erosion with is filled with intermediate tissue there.
And here the coronals on this low field gradient echo over here and stir image over here.
Yeah, it definitely looks like gout again.
Yeah, I would certainly be concerned about gout. You have these sharp little margins. If this were a malignant tumor, you could have a mass within the bone that spills out on the soft tissues. But I never seen or heard of a case where you get these speculated bone margins. Neoplasm would just dissolve everything, destroy everything, and you'd have more rounded margins everywhere. So I agree with you. I think this is much more suspicious for gout, which you can see there, and this was gout. But you can see how gout can look very aggressive, almost like neoplastic tissue, until you look carefully at how it's happening and what the details look like. Okay, Elior?
Right, so here we see that erosive change along that scapholunate interval, bone erosion in that lunate. Okay, so some synovial fluid surrounding that, or some joint effusion.
It's a recess that we talked about before. So it looks like, yeah, this could be fusion. If this is a T1 weighted M, and it's a little bit high in signal intensity for fluid, so the other possibility, this could all be just synovial thickening. And you just need to look at the pulse sequences, and especially the T1 weighted images to help differentiate that. Here are the sagittal images.
Right, so we see this synovial thickening just surrounding the joint. And again, these bone erosions, could this be, another inflammatory arthropathy?
Yeah,
Maybe
so
gout.
this was gout too, and this was all the synovitis associated with gout. Yeah, where the erosions are a little bit less prominent. Okay, Tayson.
All right, so right underneath that marker over that metacarpal, looks like we have a soft tissue thickening there, and maybe a small erosion at that dorsal aspect of the metacarpal.
Here's what the axial image looks like there.
Yeah, it looks like it's very distended, and it's kind of lifting up that extensor tendon there.
Okay, and this is the PD fat sat showing just bright fluid here, but we know from the T1 that this doesn't look like fluid. This looks like soft tissue. And there we see the soft tissue thickening, a little bit inhomogeneous signal, also compatible with soft tissue rather than just a routine effusion. Thoughts here?
Again, some sort of inflammatory arthropathy. Yeah.
Yeah, gout. So I'm just trying to show a number of different cases just to show the variations in appearance that you could see with gout. And part of it, you can see that there's kind of a general theme to all of these. And gout is one of the conditions that's often not thought about, especially if it's in an atypical location and not the great toe or something. You can see a lot of destruction, so a lot of people will often go immediately to a tumor or metastatic disease. When if you look carefully, you can often make the diagnosis correctly of gout and send people in the correct direction for their workup. Elior, what do you think of this case?
Again, we see bone destruction, that first, involving that first IP joint, soft tissue thickening.
Yeah.
Be concerned for gout again.
And then here we can see that there's marked thickening, kind of a speculated portion here, but we can see there's marked instability here with really a completely discombobulated joint. So when you see a discombobulated joint, you think about could possibly be neuropathic disease, but you generally with neuropathic disease you don't just get these large soft tissue masses. So this is much more in the category of a gout. And this was another gout. Okay, Tayson.
All right, so I think at the volar aspect of the wrist, we see some subcutaneous thickening there.
Okay. And it's not very broad on the PD fat set. And it has these kind of spiculated edges. So this really looks like some sort of a fibrous lesion, right?
Yeah. Um, we're on inflammatory stuff, but it's probably causing like a contracture, right?
And it looks like it may be flexed here. Yeah.
Yeah.
So what are you thinking about?
I mean, I was thinking of Dupuytren's contracture, but um, yeah.
Good thing to think about. Yeah. And it can be here. It often will it can involve the subcutaneous tissues. It will often involve the tendons also, which I think we'll see in a minute. So this is Dupuytren's contracture. Okay, Elior.
60-year-old female, history of old fifth fracture, mass, and contracture. Similarly to that previous case on the palmar aspect of the third digit, this nodular, low signal, looks like fibrosis. More proximally, yeah, some more kind of nodular thickening there. Yeah, again, I'd think about Dupuytren
Okay.
contracture.
And then here they're actually flexor tendons. These aren't displaced flexor tendons. There really shouldn't be any
Yeah.
fibrous normal anatomic structure in that location. And these again are, and here we can see why they're producing the flexion, extending in the soft tissues. So again, Dupuytren's contractures. Okay, Tayson.
All right.
In a little different location.
53-year-old male, female with skin thickening. Looks like there's
From Australia.
prominence there over the first or the proximal interphalangeal joint.
Right. That's what it looks like under ultrasound.
But it looks like it's I don't know.
So
No,
are you familiar with Garrod's nodes?
I don't think I've ever heard of that one.
Called knuckle pads. These are thickening of the soft tissue overlying the knuckles. I think that, yeah, here we go. This fibrous tissue. It's probably due to repetitive trauma, typically seen in workers. So it's probably just a kind of like a pressure lesion, except over the dorsal aspect of the joints. Okay, Elior.
All right, so here it looks like a T1 weighted image.
Yep.
Yeah, just this lobulated masses in the soft tissues.
Okay.
Yeah, maybe some infiltration of the interosseous muscles.
There's the PD fat sat. So
Yeah, PD.
here and
Yeah,
here.
not a lot of fluid.
Yeah. So these were biopsies, and this was muscular neurotic fibromatosis. So this is another fibromatosis that can be kind of anywhere. The Dupuytren's is typically volar to the flexor tendons, but you can get fibrous depositions and other soft tissues too, typically in the hands. A lot of these may also be due to trauma in people who are work a lot. Okay, Tayson.
All right, so looks like in the hypothenar soft tissue there,
Yeah,
there's some intermediate signal soft tissue there that enhances. Kind of looks like scar to me.
yeah, because they have these kind of spicules that look kind of like, I agree with you, it looks like scar. And then here we can, it's kind of also looks like it maybe a little kind of infiltrative type, but it has these kind of spiculated margins. And this is called plantar fibromatosis, also a fibrous lesion. In some areas, these fibrous lesions can be very aggressive, and in other areas less so. Okay, but it looks like a fibrous lesion. Okay, Elior.
Okay, so we've got a bone scan on the left with uptake regions of the IP and first MCP joints. The MR, the T1. Yeah, let me see. The IP joint looks pretty unremarkable.
Maybe a little bit of osteophytosis, but I agree.
Mm,
And the metaphyseal joint.
some thickening of the capsule. Yeah, edema and thickening of the capsule. Same on the IP joint.
Here are the sagittal images.
This is a PD fat sat.
Yeah.
Looks like effusions.
Yeah, fusions.
In those joint spaces. A little bit of edema within that first metacarpal head.
Maybe in the proximal phalanx there. Okay. Yeah, this is a patient who had previously had surgery, and this patient presented with pain, and this is a regional pain syndrome, or in this case, reflex sympathetic dystrophy, and the new name people like to use is regional pain syndrome. And it's kind of idiopathic, probably has to do with some sort of a nerve dysfunction, typically after trauma, commonly surgery. Okay. Tayson?
All right. Well, our history is consistent with the finding here. Have subluxation of that first IP joint. That distal, that phalanx looks very irregular at that proximal aspect.
And this one also had kind of sharp edges, a little bit closer chains, kind of a soft tissue mass around it. So certainly I think gout should come in your mind.
Yeah, but it's just not eroded in that kind of
Yeah.
classic fashion, like
Right.
marginally, you know?
The other things when you get discombobulated joints like this is you have to think about would be neuropathic type disease from repetitive trauma. I think this kind of these kind of findings are due to repetitive trauma, but this was biopsied at that particular time to try to come up with a diagnosis, and you can see there's a lot of instability here, and the diagnosis was dendritic synovitis, which is really kind of a pathologic diagnosis. Here we can see some big osteophytes, which I think is what you see pathologically when you have chronic instability and a lot of trauma. And here just I think most commonly, we see it in the foot with diabetes with neuropathic disease. We can, but biopsy tends to come back with that as a diagnosis. Here's in the cervical spine, we can see that there's central stenosis. This patient then had neuropathic problems within the upper extremity, and also had neuropathic osteodystrophy. And we've talked about this before. These people have less pain, therefore they can go on and continue to use joints. It's not very painful but they can use them even when they're abnormal and when you have fractures and loss of articular cartilage, and they increase use at a time when the joint is abnormal and injured, leads to further disruption of the joint, discombobulation of the joint, instability, uh, fractures, and so forth, which in the end, the pathology comes back dendritic synovitis. So,
So that would be the same as, what happens in your shoulder as well.
yeah,
Like the,
and it typically happens in the shoulder when you have cervical spine disease.
yeah.
Then you'll get loss of sensation. So this dendritic synovitis can be caused by neuropathic osteoarthropathy, osteonecrosis. You can get chronic repetitive trauma to the joints and a disrupted joint, CPPD deposition, psoriatic arthritis, chronic osteoarthritis, and times when you get osteolysis.
Okay.
So it's probably not a specific pathology. It's a findings that you see within the tissues when you have chronic repetitive trauma to a damaged joint. Here you can see on the plain films all these typical damaged joints, and this is a case where you could, if you biopsy it, you'd probably come back with dendritic synovitis. Okay, Elior.
Okay, we have a 41-year-old female, 3 days acute pain and redness. Rule out infection. Looking at that first IP joint, I think those look like sesamoids, but they look irregular.
Okay. Right, here's what the MR looks like.
Yeah, on T1, yeah, not much there. On the PD fat set, some surrounding edema, maybe a small joint effusion. On the PD, some soft tissue thickening there.
Yeah.
Calcific.
So
Okay.
this is something that you haven't seen much of, but is in the literature, which is acute calcific periarthritis of the thumb. It's probably similar to CPPD deposition, and it's probably from overuse and repetitive injury to the IP joint. Okay, Tayson.
All right, 49-year-old male with chronic lateral wrist pain.
I want to check something just 1 second here. Oops, that's not what I wanted to do. Okay. Go ahead.
All right, so looks like severe degenerative change and remodeling of the triscaphe.
Right. Okay, this is 32509. Maybe even some fusion here.
Yeah.
Okay, this is 4/13/2010. So let me go back again. That's what it looked like on 09. Here's what it looked like 2010. So they probably did surgery, right? Or missing.
Yeah, did they resect the trapezium?
Yeah. Yeah. So this was arthroplasty for patients who have triscaphe arthritis that's can't really be, the pain can't be handled by other techniques.
Okay.
Okay, so I think we're through with the inflammatory sections here of the wrists. Uh, uh, so I'll see everyone tomorrow.
Okay.
Thanks.
Good. Thank you.